So thank you everyone for joining this session today, which is a special session in the collaboration between the YNP leadership and GlomCon. It will be today is a focused review of literature, basically, including scientific methods and the latest in nephrology. It can be all topics, not GN. And today's topic is led by Dr. Kate Stevens, consultant nephrologist from the renal unit at Elizabeth University Hospital in Glasgow, on the issues related to contrast nephropathy. Two articles from NDT are being referenced with regard of should we try to avoid contrast media in patients with CKD, something we see all the time when we are in service, at least twice a week. I see that question coming up. On the panelists are Professor Dennis Fouque. He is the chief of the Division of Nephrology at Hospital Edouard Herriot in Lyon, France, editor-in-chief of the Journal of Renal Nutrition in Philadelphia, and editor-in-chief of Nephrology, Dialysis, and Transplant, past president of International Society of Renal Nutrition and Metabolism, and Kate Digo, executive board member and founding editor of Cochrane Collaborative Renal Group. We have Dr. Swapnil Hiramath as panelist as well, associate professor, MPH, Department of Medicine, University of Ottawa, and Dr. Liga Vaguspak, assistant professor and associate program director of renal disease and hypertension, McGovern Medical School in UT Health. Dr. Johannes Schlondorf as an assistant professor, Harvard Medical School, and course co-director of the GlomCon initiative here with me at the Bethesda Deaconess Medical Center in Harvard Medical School, and Dr. Socrates Stompos from Specialty Register in Nephrology, Renal Unit, Queen's Elizabeth University Hospital in Glasgow. We are full house. Thank you everyone for attending and joining. And with this, I give the micro to Dr. Stevens.
Okay, thank you. So we have selected two papers that's different to GlomCon's usual topics. We're going to look at contrast-induced nephropathy and whether we should be trying to avoid contrast media in patients with CKD. So this is based on two papers that were published in NDT earlier this month. So it's essentially a pro and con debate. So as Ali said, it's obviously a very topical subject and we get asked about it multiple times a week. I thought what we would do is just go through both papers briefly, and then I've got some conclusions, and then I thought we could have a discussion about it at the end. So we take the first paper. This is from an Austrian group, and they were in the pro camp, so their arguments for avoiding contrast media in patients with CKD. So they started off by talking about the strong correlation between contrast-induced acute kidney injury and adverse outcomes. So that should be slide number 3, Alfie, if you've got that up okay.
Hello? Kate, yeah?
Yeah, so slide number 3, argument 4.
Yeah, we are there.
Okay, yep. So they talked about the correlation between contrast-induced acute kidney injury and adverse outcomes. So they were talking about cardiovascular disease, renal replacement therapy, and mortality. And they cited a 2015 review article, which went through some of the pertinent trials in the literature. We'll come back to that in a second. They also said that various bodies, including KDIGO, have produced guidelines with recommendations for how we manage patients who are undergoing contrast-enhanced studies. And they essentially infer that because big organisations have produced guidelines, it must be true that we need to think about this. They talk about contrast being cytotoxic in vitro. I think the pathophysiology and the mechanisms aren't clear, but there's various different theories, so including that contrast causes apoptosis, that it causes release of vasoconstrictor cytokines, and there's an imbalance in reactive oxygen species, so you have less nitric oxide and more of reactive oxygen species. So we know that contrast is exclusively eliminated by the kidney, and we know that the half-life is prolonged in CKD. And we also know that there are contrast-specific factors that are important, so the ionic strength of contrast, the osmolality of it, the viscosity of it. And we also know that when we look at patients who've had contrast who then develop acute kidney injury, that there are patient-specific factors, and again, we'll come to them more in a second. So with all of that, they are quite strongly in favour of the fact that contrast must be nephrotoxic. They go on to define contrast-induced acute kidney injury. So they talk about a 25% relative or a 0.5 milligram per deciliter absolute rise in serum creatinine within 72 hours of a contrast-enhanced procedure and without an alternative explanation of the acute kidney injury. That's important because I think it becomes clear that it's quite difficult to determine that there's not an alternative explanation in these patients. Now, it's fleeting, so if there's a rise in creatinine that's fleeting, why should that have such adverse effects? They talk about creatinine not being a good marker of renal function, and we all know the reasons for that. But they then go on to discuss the fact that small rises in creatinine have been shown in other studies longer term to have adverse effects. And they talk about the AKI and CKD continuum. And they postulate, along with others, that perhaps an acute kidney injury causes effectively a systemic inflammatory response and accelerated aging within the kidney. So they then spend a bit of time talking in detail about the risk factors for contrast-induced acute kidney injury. So they start off with the patient-specific risk factors. So again, you're all familiar with these. So older age, patients who have underlying conditions, for example, diabetes, heart failure, and importantly, people who have pre-existing renal impairments, so chronic kidney disease. So they cite two big trials, the Poseidon trial, which had almost 400 participants with an average GFR of about 48 mils per minute, so not really significant renal impairments. And they found that there was an 11.4% incidence of contrast-induced acute kidney injury, and at 6 months there was increased mortality and increased myocardial infarction. We then talk about the Preserve trial, which had almost 5,000 participants. Again, although they had impaired kidney function not marked, so an average eGFR of about 50, and there was a 10% incidence of contrast-induced acute kidney injury. So in that study, they had two groups. So the groups received sodium bicarbonate and saline, and either placebo or N-acetylcysteine. And they found that their primary endpoint was similar in both their groups. So the primary endpoint was death, the need for dialysis, or a 50% persistent increase in creatinine from base at 90 days from having received the contrast. So they cite those studies as being for the idea that we should be avoiding contrast. Then go on to talk about it not being a standalone disease entity, as I alluded to, and they said that there's often acute kidney injury misclassification, because as you can imagine, it's often very difficult in the patients who are receiving contrast scans, particularly for cardiology procedures, to just determine exactly what it is that's caused the rise in creatinine and the acute kidney injury. And they mentioned briefly that a lot of the studies are flawed, and a lot of the studies are based on observational data, which clearly have inherent limitations. So they move on to talk about contrast-specific risk factors. So there's some evidence that isoosmolar contrast has a lower risk of causing an acute kidney injury than low osmolar. There have been meta-analyses, and again, we'll talk about that a bit more at the end, but the meta-analyses have suggested that that's perhaps not clinically relevant. The only exception would be iohexol, which does appear to cause increased nephrotoxicity compared to other contrast agents. They then make the argument looking at intra-arterial contrast compared with intravenous contrast. And they cite a fairly recent study where there was almost 2,000 patients who both received an intra-arterial contrast load and an intravenous contrast load, and there wasn't a difference in the rate of contrast-induced acute kidney injury from intra-arterial compared with intravenous. So they have then concluded from that means even intravenous contrast confers a not insubstantial risk of acute kidney injury, which is important because the CON group also used the same argument, but they interpreted it differently. So we'll come to that in a second. So to conclude, should we avoid contrast in CKD? So the four groups said that it was difficult to prove cause and effect, but they felt there was no doubt that the risk of contrast-induced acute kidney injury is real. They weren't clear whether or not in the literature it's a mediator or a marker, but it certainly seems to be linked to adverse outcomes. And they've essentially concluded that CKD patients are probably particularly susceptible, but that's not enough receiving contrast. And so in each individual patient, you have to consider the diagnostic and prognostic benefits of a contrast-enhanced scan, and you shouldn't deny patients who have risk factors a contrast-enhanced scan on the basis of just risk factors alone. They suggest that you should look at all possible diagnostic alternatives. So for example, VQ scans, MRI scans, ultrasound, perhaps FEMRA, which again we'll talk about a little later on. And they said that it's not a black and white area, prevention is better than cure, but they feel that you should very carefully consider if a contrast-enhanced scan is necessary, and if it is necessary, then you have to adopt an approach which will minimise the risk to the patient. So we then move on to the con group. So these are the people who have said that we should not be trying to avoid contrast. So they start off by talking about the concept of contrast-induced acute kidney injury having led to an irrational deviation from optimal patient management, and they suggest that we become quite fixated on the contrast issue and perhaps to the detriment of the management and investigation correctly of our patients. So they say that iodinated contrast is nephrotoxic, and they talk about various of the studies which have looked at the pathophysiology of contrast and its effect on the kidney at a cellular level, but they say that they feel it's been erroneously blamed for acute kidney injury. So they say that acute kidney injury post-contrast is multifactorial. So again, what we alluded to before, so volume depletion, sepsis, hypotension, coexistent prescription of various drugs, diabetes, CKD, and advancing age. So lots of things that patients who are getting contrast-enhanced scans, particularly in the acute setting, might have. They talk about the wide variation in the published incidence of contrast-induced acute kidney injury, and they acknowledge that that's because the definition can vary, the populations of interest can vary, and obviously the type and volume of contrast can also vary. And again, they mention that the literature is quite difficult to assess because a randomized controlled trial is virtually impossible for ethical reasons. So they then go on to talk about the flaws in the argument against contrast. So they start off by talking about acute kidney injury in hospitalised patients. So we know that
we are on slide 7, right?
We are on, hold on, 1, 2, 3, 4. We're on slide 8.
Okay, thank you.
Flaws in the argument against contrast?
Yeah.
Yeah, so they talk about acute kidney injury generally, and the fact that the instance of acute kidney injury is exceptionally common in hospitalised patients, so even in patients who are not receiving any form of contrast. So up to 30%, they cite several studies which look at acute kidney injury in the hospital setting. And they ask whether or not perhaps the instance of contrast-induced acute kidney injury, which is quoted, is perhaps an overestimation given how common acute kidney injury is in the absence of contrast. There are several studies that have looked at the effect of contrast versus non-contrast in the development of acute kidney injury, which they quote. The difficulty with a lot of these studies is that there's not a control group. So they use things like propensity scoring and risk scoring to try and work out what the actual difference is. And again, similar to the Pro group, they talk about there being no causal relationship between acute kidney injury and contrast. And they, unlike the Pro group, they are quite vitriolic about the fact that there are lots of studies which don't have clinically relevant outcomes. So they don't look at things like dialysis being necessary and mortality. And as I said earlier, they also look at the intra-arterial or the alterment in the intra-arterial or intravenous contrast, and the fact that the study from Tong and colleagues with the 2,000 patients showed that there was no difference in the incidence of contrast-induced acute kidney injury. And their interpretation of that is that means it's safe because intra-arterial contrast would be a big contrast load upstream of the renal artery, and so therefore you'd be delivering a large concentration to the nephron and a significantly larger concentration than you would with intravenous. We know that contrast does have nephrotoxic effects, and so therefore if there's no difference in the instance between those receiving intra-arterial and intravenous contrast must be safe. So that's a slightly different interpretation of the same study. They then interestingly go on to talk about the cardiac literature. And they quote several studies, and the studies, as with a lot of the cardiac trials, have big numbers in them, but they're noteworthy because they often have control groups with similar acute kidney injury risk profiles as the treatment group, as the group that received the contrast. That makes them, I suppose, slightly better comparisons. So from the studies that they quote, what they highlight are that these studies essentially conclude that factors other than contrast play a dominant role in the development of acute kidney injury. So in cardiac patients specifically, the severity of an ST elevation MI and the hemodynamic sequelae, so for example, hypotension and whether or not somebody requires an intra-aortic balloon pump would be predictive of acute kidney injury, but there isn't any association with the type or the volume of contrast that's used. They also mention a study where there's evidence that optimal timing of coronary intervention, so PCI, reduces acute kidney injury. So that would suggest that the adverse hemodynamic consequences of myocardial infarction are play a more significant role in acute kidney injury than perhaps previously estimated. And in fact, by perhaps denying patients an angiogram or a PCI, and these procedures perhaps being slightly delayed, we might be doing them more of a disservice. So what they concluded from the trials that they quoted is that AKI is related to age, baseline renal function, heart failure, and hemodynamic instability, but not to the use of contrast. And then the next slide. So their conclusion, so should we avoid contrast in CKD? So they said that we should look at individual risk factors, we should look at contrast risk factors. They feel strongly that acute kidney injury is overestimated and it's much more often related to disease processes and procedural risk factors. So it's an individualised risk benefit, and we should proceed with intervention having first exhausted the use of non-contrast studies before moving to contrast studies. If a procedure is elective, we should try to prehydrate patients and withhold nephrotoxins. And if it's acute, optimization is often not feasible, but that shouldn't discourage the use of contrast. So if you then move to the next slide, so there's a pro-con debate, should we avoid contrast? So we've got two papers, and to my mind, they both say exactly the same thing. No, we shouldn't avoid contrast, but we should think about it before we go ahead and give it, and we should consider and manage other risk factors for acute kidney injury. So I'm not sure that we're any further forward in terms of actually specifically answering the question with evidence. If you move to the next slide, why have they concluded the same things? So I think the problem in this area is that there's lots and lots of trials and there's several meta-analyses, but there's very limited meaningful data. And that's because the clinical trials are generally of low quality. And so if you take a meta-analysis, it can't generate consistent results because it's obviously based on the trials in which it includes. So some of the problems are that often it's low-risk patient groups that are included in the studies. Often they're inadequately powered, there's often very small numbers, and they often focus on these short-term rises in creatinine, but don't actually have a lot of data about clinically relevant outcomes. So whether somebody is on renal replacement therapy, whether or not somebody dies, a sustained rise in creatinine. If you then move to the next slide. So we know that there's no causal link established between contrast-induced acute kidney injury with clinical relevant outcomes. We know that there are significant limitations in the research into the intervention strategies to prevent contrast-induced kidney injury. The only evidence we have really is that dehydration is probably advantageous, and there may well be other reasons for that. So ultimately, we shouldn't deny patients who've got chronic kidney disease who have a clearer indication for a contrast-enhanced procedure, those procedures. We should be wary of underutilising contrast-enhanced procedures in patients who've got pre-existing kidney disease. So there's lots of observational data that indicates that coronary angiography, for example, maybe a slightly controversial subject, but it's underutilised in patients with CKD. And we know that cardiovascular disease is the leading cause of death in these patients. We also know from the cardiac studies that patients who have PCIs at the appropriate time tend to do better. So those are things that we should think about before we say that a patient shouldn't have a contrast-enhanced procedure. And I think, like a lot of these areas, ultimately what is necessary is a large clinical trial that's adequately powered and has got high-risk patients enrolled into it. And we need to then obviously look at things that are more meaningful clinically, so a persistent decline in kidney function, the need for renal replacement therapy, and death. And then I just, on the next slide, a few papers that I thought were potentially of interest to the audience. So a couple of them are meta-analyses. So two big meta-analyses which looked at the first bit of the types of contrast that are used, and essentially found, as the pro group said, no real difference in whether you use isoosmolar or low osmolar contrast. The thing that they were able to determine was that iohexol seemed to be toxic. And the second, which included 86 trials, which is a reasonable number, and looked at interventions to reduce contrast-induced acute kidney injury, so sodium bicarbonate, N-acetylcysteine, and essentially couldn't really find anything that actually consistently demonstrated a benefit. And that, I think, is as we've said, that the problem is that the quality of the data which is being fed into the meta-analysis is perhaps not as good as we would like. And then the last paper is actually from Socrates, who is with us. So it's looking at an alternative form of imaging, so FEMRA. So I'm not going to talk about that, but Socrates would be happy to bring that into the debate, because Socrates and his team have shown that that's a fairly effective and safe way of performing imaging, which might otherwise have utilised contrast. That's it.
Awesome, terrific. So, Kate, how do you? So basically, is do you then now approach patients with CKD any different based on your summary and assessment? Any difference than a regular non-CKD patient when it comes to the choice of using CT imaging with contrast, or do you have any other any different threshold with regard of applying this? Clearly, we all feel that it shouldn't be denied, and we should be thoughtful about that. But is there any? Do you treat them any different?
So, no is the answer, because I've always been in the camp which is kind of thought that if somebody needs a scan that's potentially life-saving, they should have the scan, and we just have to accept that the kidneys take a hit. Now, clearly, if somebody comes in electively, then I would do sensible things. Like I would stop the ACE inhibitor, dehydrate them, and look at other risk factors. But if somebody comes in acutely and they need a contrast-enhanced scan, then I've always kind of felt that they should just get the contrast-enhanced scan, and we just have to pick up the pieces afterwards if required. Maybe a little bit gung-ho, but that's always been my approach.
Okay, and okay, excellent. Thank you. I would like to open this up now to the panelists to comment on these two opposing views, and I would like to start with Professor Folk. Professor Folk, so you're the editor-chief of Nephrology Dialysis Transplant. So if we draw a parallel to the state powers and divide them between the legislation, the executive, and the judiciary, kind of the editors and journals can be considered as the judiciary in the sense that they kind of influence what we see and ultimately judge what is worthy to be seen and not. We have had 30 years of confusing studies swaying us one way or the other. How do you assess the quality of studies, observational data? Clearly, experimental randomized trials are not possible in this domain. How can you, from your perspective, help us make sense of that? I can not hear you.
Hear me?
Yes.
Okay. Thank you for.
You're very muted. If you perhaps can move toward the micro a little bit more and speak louder. Oops. That was it. Okay, I think Dr. Fook lost the connection. While we are waiting for him to reconnect, I would like to have Dr. Hiramat Swapnil take on the lead here.
Awesome. Thanks for the invitation, Ali. I have got like a page full of notes taken out as Kate was talking. That was a wonderful discussion, Kate, of the two papers. While we are on this slide, actually, what I would like to first point out is the first two papers on your list of 4 papers are papers that no one should ever read on contrast nephropathy. I'm opinionated, and this is a strong opinion I'm expressing, but the one by Eng, for example, and Subramaniam, they are terrible meta-analyses. Annals should never have published them. If I was a reviewer, I would have rejected them. And I'll say why. I'll just say a couple of things about why. First is the Eng paper, which suggests that iohexol may perhaps be superior to iodixanol, which is low osmolar versus iso-osmolar. So it hinges on one paper. So there was a study called Nephric by Asplin. It was funded by the maker of those two agents, and the maker was trying to bring this new agent iodixanol or VCPAC into the market. The trial is a very small trial of just about 100 patients. It was stopped early as soon as they saw a benefit. And the benefit is huge. It is implausible that anything could have a benefit of this nature. Naturally, it was positive. So it was published in a journal based in Boston that I will not name now because Andy is in the room. So that had a huge impact. And this meta-analysis has huge statistical heterogeneity. There's huge publication bias that these meta-analyses completely ignore. If you take that single trial out, the Nephric study, there is no difference between low osmolar or iso-osmolar. So I don't think that really is true. And I would say just let both of them are similar. The second one, the one by Subramaniam, is awful is terrible. It's an awful meta-analysis. They totally ignore publication bias. They do not talk about publication bias. They do not talk about the huge statistical heterogeneity that exists. So yes, the Subramaniam data came out before the Preserve was published. But even then, for N-acetylcysteine, there was a huge trial from Brazil called ACT. And that showed that there is no difference between N-acetylcysteine or placebo. Anyone who was following this literature knew that NAC does not work. But still, this systematic review suggested that, oh, NAC is better. In fact, it suggested that low dose NAC is better than high dose NAC, which is a biologically absurd result that they propounded. They also suggested that maybe bicarb is better, and Vlado Perkovic has a systematic review in Annals 8 years before this one, and we had one in CJSN also 8 years before, which suggested that bicarb and saline are probably similar. Still, they published this systematic review. So I would say these two reviews should be trashed, should be put in the garbage, and no one should ever cite them. I would take them off your list of additional reading. The only reason they should be on the list is for things that you should not do. I guess I'm getting red there because those are really awful papers. If Dr. Folk is not on, can I keep going on, Ali?
Yes. That's so non-Canadian of you, Swapna.
Yes. That I guess this topic is a little bit close to my heart.
Okay.
And as Kate pointed out, both of them do agree, and I have the same bias, is that we should not let our patients not get contrast. Right? This is something that Glenn Chertoff originally said when he talked about renalism, is that our patients with CKD are often denied treatment. They do not get coronary angiography that they deserve to get just because everyone is afraid of contrast nephropathy. Yes, there is a slightly higher risk of acute kidney injury, but I think the MI or the heart failure that they will develop from undiagnosed treatment is what is far more important than the small risk of acute kidney injury that they have. The wide variation that Kate also mentioned is hugely important. Almost every paper that you read on contrast nephropathy will start off by saying it is the third most common cause of hospital-induced acute kidney injury. That is a statistic that comes from one paper from 1983, published in the American Journal of Medicine. So it's a 45-year-old paper. It's an observation, it's a case series that they put together, and they looked at the causes of AKI. At that time, we were using high osmolar contrast dye. We don't use that anymore. The risk of AKI is way lower. People who talk about 15%, 20%, it is still an overestimate. I would say, the risk is way lower, even in patients with CKD. So we should not be afraid of giving contrast if it is necessary. That's something that I think even the pro and the con side, as well as Kate and I, most of us agree on. We still see some patients, right? The cardiologist will say, oh, this patient, we need clearance from nephrology. I think that's ridiculous. If you think the contrast is necessary, go ahead and give it, and we will deal with it afterwards.
I see Dr. Folk is with us back.
Can you hear me now?
Excellent, yes.
Okay. So coming back to the nature of the methodology of trial.
It's still very muted for some reason. If you could kindly speak perhaps louder a little bit.
Can you hear me now?
Yes.
Okay. So for an editor, what is important is the methodology of the papers. And as Dr. Stevens nicely showed, the quality of trials is not good, and there are many caveats, including randomized controlled trials. So, for example, to randomize uh, coronary angiography versus no intervention, there is many things other than iodine that could impact on the renal function. For example, if you take the patient to a radiology unit, if the patient is fasted, if he waits for a long time, for example, before the procedure, even the randomization is not really ascertain the difference to the iodine, because there are many other problems as compared to the control patient who will not undergo the imaging process. So even in randomized trials, there are many confounding factors for AKI that are probably not controlled. You follow me?
Yeah.
And then the criterion of creatinine is not a good criterion. If you measure AKI just based on serum creatinine, there are a number of confounding factors as well. We saw recently the acetylcysteine problem, which was supposed to protect the kidney, but in fact only blocked creatinine secretion. So receiving acetylcysteine did not protect the kidney from iodine, just blocked the increase in serum creatinine. You follow me again?
Yep.
There are many caveats in even in good randomized intervention. And on my practical point of view, I am here with my colleague, Dr. Dib, and we did not see any need for dialysis in the last 10 years after contrast injection in CKD patients. So I think it's not really something dangerous right now after correct prevention, as mentioned by Dr. Stevens.
But is this an observation perhaps because of being more sensitive and more selective in performing these studies?
I think we now develop a nice prevention by hydration and stopping diuretics the day before, if possible, and also stopping ACE inhibitors for 1 or 2 days to prevent hypovolemia. The problem is only hypovolemia that you want to avoid in this patient.
Okay. So we have here people from all across the globe pretty much. We have Europe, we have US, Canada, Mexico, Latin America, Asia, Middle East, and there are different practice patterns. I can speak here regionally for the East Coast, and within US even is different. Sometimes you feel like every patient coming into the hospital, as part of the routine check-in, there is a CT involved with contrast to rule out pulmonary embolism. So sometimes I feel actually, I feel good to be able to leverage the issue of kidney to perhaps thinking that unnecessary studies can be avoided. because many of them really not indicated. And I think it's a difficult debate between what is absolutely needed and what not. No one argues MI, coronary angiography, ischemia. We have Dia Vagyuspak with us, who is a program director, associate program director in nephrology. And I wonder how she is training her fellows in approaching this issue when they get paged perhaps daily, multiple times daily, about getting clearance for contrast studies. Dia?
Can you hear me?
Yep.
Perfect, thank you. So no, I think the issue lies with making sure our fellows understand the literature. I think what was, Kate nicely went over kind of the background of that. And I think it's, looking at contrast-induced nephropathy, the definition that was originally given versus how we are defining PKI now, and being able to understand, how that's affected these trials that have already been commented on before that are, not good quality literature. And so I think it comes down to a lot of what we see as the fear of the contrast, quite honestly. The CT scans are happening, but the fear of the contrast and the call that you're getting. And I think, as you kind of alluded to, you worry not only about patients potentially missing diagnoses because they're not getting the appropriate test, but here in the US, I think we tend to move towards things like MRIs, which potentially exposes them to other issues. And so I think it's really important that we're, kind of counseling the patients on there is a potential risk, understanding the literature to know that it is probably much, much smaller than we thought. We can definitely volume optimize the patient, and being aware that that is different in different patients, and educating not only our fellows but our residents when it comes to the heart failure patient. Volume optimization is not necessarily giving fluid, it's making sure they have good forward flow and they're back on their Starling curve. And so I think making sure they're understanding those kind of definitions are really important. One of the other things I've found that was fairly interesting is that I think we talk about kidney injury, are there biomarkers that may be able to help us? Those, the kind of jury is out on that in the sense of they show injury, but we don't really know the pathophysiology of what's happening with the contrast itself. There was a nice Nature paper in 2017, January, that looked at kind of just an overview of contrast nephropathy. I think they proposed some good potential mechanisms that are believable, and I think we've all seen that patient who had no other potential risk factors who got the contrast. The creatinine went up 48 hours later and they got better. That being said, we don't know what happens necessarily long-term with the ones when they recover either, and I don't think we have literature on that. So I think making sure the fellows are aware of all of those types of things, and in kind of reading up before this discussion, I think there's an ongoing trial looking at endovascular aortic repair patients and giving, they have an arm where they're doing follow-up CT scans, one arm with contrast and one without. I think the other important educational piece to that is the patients that are CKD patients with vascular disease where cardiac comorbidities are high. I think there's a separate arm of those who are getting, procedures where we're potentially putting off plaques. Is their bone mineral disease out of control and they have a different burden of, calcium, phosphorus product that the others don't have, and is that predisposing? I don't think there's an answer to that, but just to pose those kind of questions as things we need to potentially think about.
Great, thank you, Dr. Falk. Dr. Vagyuspak noted the ability for trainees to critically go through the literature, and Dr. Hiramath, while you were logged off, took on the case against the two first initial references here on this slide, that they may not be sufficient in quality in that sense that they should be guiding our decision. How do young trainees and practicing nephrologists, how should they consume literature and assess their strengths and weaknesses? Dr. Vogt, we can't hear you. I think you're muted.
Sorry.
Yeah.
Okay. So the quality of the journal should ensure quality of the papers, and it's an individual judgment to look at the meta-analysis and to hope that the results are fine. There is no, apart from the peer review, which usually ensure correction of mistakes, and the editorial decision to accept a meta-analysis, you never know if the source of data is absolutely strong or not. So the fact is the quality of a good meta-analysis should also criticize the whole process and give limitations. If the quality of trials is not sufficient, the systematic review should clearly mention that, which will weaken the strength of robustness of the results. Usually, during settings, the experts analyze the quality of the randomized trials. Some are not good at all. There is the grade system, for example, to assess the quality of reviews and randomized trials. So sometimes you have very poor research and you can't make a good guideline or a good systematic review. So I can't say nothing more than that.
Great, thank you. We have here in the chat a discussion going on in the background. I encourage anyone who is interested in joining the discussion, please unmute yourself and comment.
Ali, can I just say something?
Yes, please.
So, just, I guess, another thing to think about, and the guys in the Pro paper mentioned this. They quote a study that was published in the American Journal of Medicine in 2017, looking at why we order so many CTPAs and they're all negative. And they essentially concluded that if you use proper clinical scoring, you can reduce the number of scans that you order, so unnecessary investigations, without having a negative impact on patient outcomes. And it's a pretty good study as far as I can see. So I guess, as has already been alluded to, the coronary angiogram issue is different, clearly, but I think that one of the things about contrast being so topical that is useful is that people do think before they order things. I think that sometimes that's to the detriment of patients, but I think sometimes it's not. And I think the patients, particularly, I don't know about other countries, but I know that here we're all sort of terrified of missing a pulmonary embolus. Lots of people get CTPAs completely unnecessarily, and if you actually took a decent history and examined them, you would identify what was the actual cause of their symptoms, rather than having to organise an unnecessary investigation. So I think that being topical, whilst it's annoying to get phoned often about it when you're the renal registrar on call or whatever, I think it's important that people do think about it. And Socrates has got something, he's obviously with me, he's got something to say about the stigma, if that's okay?
Yeah.
Yeah.
Very similar situation here as well.
Hello?
Yeah?
So it's okay. So just a few brief comments, hopefully. So first of all, with regards to the pro and con debate, I think that after 30 or 40 years of us thinking that contrast can cause nephropathy, I think we're now there that we don't know exactly what's happening. the 2 or 3 recently published studies, kind of registry studies using a very good study design with propensity matching, they definitely have weaknesses with regards to the retrospective nature, potentially unmeasurable confounding, and the definition by itself is quite problematic, as we're talking about people who are quite unwell, and within the 72 hours there might be other insults contributing to the AKI, but we should definitely take them into account, and I think we can't say securely that the risk is negligible in patients with CKD or that the risk is high. There was a lot of discussion about prospective studies and if it's ethical or unethical to perform one of them, but I think we could probably perform a randomized controlled trial in these patients with a kind of an unconventional design. For example, we can include patients with various degrees of CKD who are stable, are not unwell, are not septic, didn't have a coronary event, and we just give them contrast. So they may be patients that they don't necessarily need a CT, but that might be the best way to examine if contrast is definitely nephrotoxic. And finally, last comment with regards to alternatives. Kate mentioned about the ferromoxtal enhanced MRI. This is a new technique which we're using in our center. This is still not clinically available, so this is part of a research project, but it looks like it works. So we're giving an iron-based contrast called ferromoxtal with super paramagnetic properties, and we're performing MR angiography in patients with various degrees of CKD. It's very convenient, it's non-nephrotoxic, and we're getting nice arteriograms and venograms as well. So this is probably too early, to discuss further about that.
Thank you, Socrates. I think that's a very interesting study. I'm looking forward to see more. Actually, this company is here in Waltham, and we, a colleague across town and myself, had a couple of years ago reached out to them to see if we can use it in CKD, SRD patients for purposes of contrast, basically replacing CT contrast with MRI contrast. It is an iron, the patient get that for iron replacement therapy, and it seems really that it can act as an contrast agent other than gadolinium in MRI or iodine in CT. So very exciting. Looking forward to hear more about that.
Okay, thank you.
Any other comments or questions here? Yeah?
Can I say a couple of things, Ali?
Please.
I have already said a lot, but I just wanted to make 2 points. One is on the issue that has been touched by Dr. Folk and you about the understanding the weaknesses of trials, of studies. And let's touch on the observational studies, which are not on this list, but that have driven the discussion. There have been many observational studies in the last 5 years. A bunch of them have come from the Mayo Clinic, from Jennifer McDonald and her colleagues. And there's one huge one from Willem Leens and Glenn Chertow in JSN in 2016. So these were observational studies which looked at patients who received contrast, and they matched them with using very sophisticated propensity score matching or other regression-based analysis with patients who did not get contrast. And all those studies suggest that there is no increase in AKI risk with contrast. But there are 2 things that you should keep in mind when you're looking at all those studies. A is that I do like that because I think contrast should not be avoided when it is necessary. But like Dr. Folk pointed out, I think from 40 years ago to now, the risk of contrast causing AKI has actually gone down because we have better contrast agents. We are also more careful about patient selection. We are not giving them in patients who are at high risk. We are careful with the amount of contrast we are giving. And because of that, I suspect the true risk of contrast causing AKI has gone down from 40 years to now. So that is the fact that truly the risk of contrast causing AKI has decreased. But to say that there is no risk is also a big red flag for me. I have seen patients, all of us have seen patients who have had contrast, who have received contrast. It's usually in the setting of arterial contrast, angiography. And we have seen patients who had AKI with nothing else, as Dia pointed out. So I don't accept when people say that it does not exist. It does exist. So why are these studies showing the results that they show? You know, they are propensity score matched. They have used sophisticated statistical techniques. But the big thing here is that all these techniques cannot take away from the fact that the outcomes and the exposures are not ascertained properly. And this takes some thought. It's not something you can look at the analysis and say, oh, this is a good analysis. Even if you're matching the patients well, there is something that made the clinician use the contrast for a certain particular patient and avoid the contrast for the patient who otherwise looks exactly the same. So they are two well-matched patients, but for some reason, Ali is deciding this patient gets contrast and this patient does not get contrast. Why is that? So there is a selection bias. I know something that the big database does not know. I know that this patient who I'm avoiding contrast in is at a high risk of AKI anyways. So that's the selection bias. It's not just confounding, it's selection bias that no amount of analysis or a big database study or a sample size is going to overcome. That's something that you just cannot get rid of. And as a very important example, if you look at the paper from Glenn Chertoff and Jason in 2016, they showed that overall, 5.4, it's a few million patient study, so it's huge. And I commend the authors for doing that study, but the risk of AKI was no different from both of them. But if you tease down the results, you see that actually after adjusting, the patients who got contrast were at lower risk of AKI than the patients who did not get contrast. That is an absurd result, right? It just shows you that that clinicians are avoiding contrast use in patients who are at high risk of AKI. And that's why the risk of AKI is higher. So contrast has no role to play. It's the unknown factor of the clinician's thought process that is causing this artifact. So whenever you're reading these observational studies that show that, hey, there is no difference with AKI, take them with a huge pinch of salt. So that's one big issue that I just wanted to put out of the way. And the last point before I give the mic to others is that what's often mentioned is that we should withhold nephrotoxics when someone is getting a contrast. What is the evidence base for that? There's zero evidence base for that. So, people talk about, hey, someone's getting a contrast, so let's stop their metformin. That's completely an American thing driven by lawyers. And I won't go further into that. But the other one is about avoiding ACE inhibitors and ARBs. There is no evidence that whether you withhold or you allow the ACE inhibitor to be continued, that there is a difference in the risk of AKI. There's a lot of theory. But if you look at the data, there was one trial that showed that there is no difference between the two. Laurie Tomlinson has done a systematic review showing that, the sick day rules, there's little data to support the sick day rules. So it seems nice that we should withhold the nephrotoxic insults, but I would wish that that's the area where I think a trial should be done to see if this is really justified. So that's my sound soapbox. I'll give it to the others now. Thanks, Ali.
So can I say one thing to that? So there's also evidence, just going on from what you've said, that actually, not in the contrast setting, but stopping the nephrotoxic drugs has potential adverse effects, and that people come back in with heart failure because the diuretics have been stopped, or they come back in with other cardiac problems because they've had the ACE inhibitors stopped. So I think that is a very valid point.
Yeah, excellent. Great. Thank you so much, everyone. Thank you, Dr. Stevens and Dr. Stampos for leading the discussion. And thank you so much for the panelists, Professor Fock and Wagusbach and Dr. Schlondorf and Dr. Hiramath leading and running the discussion. 2 more points. We have maybe 5 minutes left. 2 other small issues in that domain are coronary angiography and pre-transplant evaluation of patients with CKD stage 5, which is also always kind of an angst-provoking situation, and the use of contrast in patients on dialysis, often more peritoneal dialysis than hemodialysis, with consideration of maintaining renal reserve, etc. Do people have any approaches with any particular approaches in this too?
If I can jump in again, Ali, I'm jumping in because we have actually just completed a systematic review the ISPD. It's all observational studies, but it shows that there is no impact of using contrast on the residual renal function. They are all observational studies. They are not great quality, but it suggests that using contrast in patients on peritoneal dialysis may cause a decrease in the urine output transiently, but like we see in the non-PD patient setting, right? Usually contrast-induced damage is temporary, and as Dia mentioned, the patients recover. And that's what we see is that by about 2 weeks, the kidney function is back to baseline. So I would say we should not avoid contrast in PD patients, even if they have residual renal function, and watch out for a paper coming out in the next few months.
Any other thoughts, comments?
No, I just want to say, I mean, I agree completely. And I think that the next step is how do we educate those that are not nephrologists? Because I think, you know, that educating our trainees and us as nephrologists so we can present this data in a way that the ER understands where we're coming from, and people are making good clinical decisions to give contrast when it's appropriate. So we're doing the best to take care of our patients.
Great. Well, thank you so much for Kate Stevens for bringing together the Young Nephrologist platform here into running a few of these sessions where people from other places come discuss literature. Thank you so much for Professor Folk for participating and giving the perspective from the editors side, and well, we look forward to seeing you all back soon. Thank you all. Have a good day.
Thanks, Ali.